Hi, everyone. Thanks for joining this third and final part of the trilogy on screening and prevention of prostate cancer, authored by Dr. Sigrid Carlsson from Memorial Sloan Kettering. She is going to finish up talking about incorporating MRI into our algorithm. Sigrid, again, thanks for taking the time to put these together.
Hello, my name is Sigrid Carlsson, and I'm an assistant attending epidemiologist at Memorial Sloan Kettering Cancer Center in New York, USA. And this is the third part in our Platinum Lecture Trilogy about screening and prevention of prostate cancer in 2021. And I'm very grateful for this opportunity to give this talk for grand rounds in urology. So in part 3, we will discuss incorporating MRI in early detection of prostate cancer. And there has really been a major shift in recent years on how we use MRI in prostate cancer screening and early detection. So EAU guidelines now in 2021 says, to begin with, do not use MRI as an initial screening tool. And I think that is the consensus around the world as of today, that we don't start with just the MRI, but we do a PSA test, GRE, there is some indication or suspicion of prostate cancer, and then we move on to order an MRI or other tests. How about then if we have men who are biopsy naive but have an indication for biopsy? Well, the EAU guidelines now recommend to perform MRI before prostate biopsy. They also recommend the same thing for men who have had a prior negative biopsy. And this goes also for the AUA position statement that supports MRI before biopsy in all biopsy naive men. And similarly to the EAU, the evidence is insufficient to recommend MRI for screening, but they do recommend it before biopsy in all men. And NCCN similarly recommends MRI if available. So it says it's recommended that MRI should precede biopsy and image-guided biopsy techniques be employed routinely. So this is now a major shift from the guidelines from just 1 or 2 years ago. So here's an example of what a multiparametric MRI could look like. And here you see an example of a Pirates 4 lesion where you have a high probability of clinically significant cancer. The next question then becomes, what do you do with these images on MRI? So Dr. Kimia Koestani recently defended her PhD thesis in Gothenburg on this topic of MRI as a screening tool for prostate cancer. And she had these really nice photos of an apple with biopsies representing the systematic biopsy, the targeted biopsy, or the no biopsy at all. So the EU guidelines recommends that if an MRI is positive, that you combine the targeted and systematic biopsy, and this is for biopsy naive men. But then in contrast, if the MRI is negative and the clinical suspicion is low, then you can omit biopsy based on discussing with the patient, so having a shared decision-making conversation. It's important to notice, though, that the strength rating is considered weak. So that means that the results that have been seen in large trials might not be generalizable to all situations. So it might not be safe to omit a prostate biopsy everywhere. We cannot be sure that we don't miss high-grade disease. And in the prior negative biopsy setting, the EAU guidelines recommends that if the MRI is positive, that we only perform targeted biopsy. And if it's negative and the suspicion of cancer is high, then you perform systematic biopsy, and again, based on discussing with the patient. The NCCN guidelines then recommends to consider MRI in centers with MRI availability and with experience and expertise in MRI interpretation and targeting. And this is important, and we will discuss this more. And the NCCN guidelines also say that some advocate for excluding systematic biopsy in those undergoing targeted biopsy, but most advocate for a combined approach, as some high-grade cancers are uniquely detected using the systematic approach. So the NCCN takes a more conservative stance as opposed to the EAU guidelines. And the NCCN also says a negative MRI does not exclude the possibility of cancer. And back to then experience and interpretation. So here are two painters. You have Matisse and Picasso, and they draw a portrait of the same man, and you can see two different interpretations. And this is figures that I received from Professor Hedvig Ritzak, who's the chair of the Department of Radiology at Memorial Sloan Kettering. And the same goes with interpreting MRI images. And Hedvig's group has really shown that if an MRI is read by a general MRI radiologist, you have a lower predictive accuracy compared to if the MRI is read by expertise in genitourinary radiology and MRI. And here's another study showing the same thing, that expert readers have a higher number of negative MRIs and a higher negative predictive value. So experts are sort of more confident, and this will lead to less overcalling and fewer biopsies. Again, another study that shows, if you compare MRI to whole month pathology, that MRI detects less than half of all and less than 2/3 of clinically significant prostate cancer foci. So MRI can really miss a high-grade disease as well. And smaller, low-grade, multifocal, and non-index tumors with lower PSA density were more likely to be missed. And the same finding was seen by Dr. Kuestani's work in her thesis, that prostate MRI had a moderate detection rate of 78% for clinically significant disease when compared to whole month pathology. So the question is it too early to omit systematic biopsies in men with negative MRI outside specialized units? Because a lot of these studies that have been done, the PROMISE, Precision, and so on, have been performed at centers of excellence. So MRI and targeted biopsies can really help you make a correct diagnosis. You can improve the detection of significant disease, reduce the number of unnecessary biopsies, and reduce overdiagnosis. But a negative MRI does not obviate the need for systematic biopsy as of yet. So here's a man who's asking his doctor, my MRI was negative, can I still have prostate cancer? And the answer is, yes, you can. And from this systematic review, you have a meta-analysis of 42 studies. You have an NPV, a negative predictive value of 91%. So that translates into a false negative rate of 9%. You also see this variation between 88 and 93%. So it really depends on where your MRI was done. So you can see this massive heterogeneity across the included studies. The same goes for the other way around. If the MRI has been positive, but the biopsy was negative, this man is asking, can I still have cancer, doctor? And again, the answer is yes, you can. And the false negative rate is 7% according to this systematic review. And again, you see a variation between 90 to 95% in the negative predictive value. So there is this saying, a chain is only as strong as its weakest link. So in order for this concept of pre-biopsy MRI to be successful, you really need access to high quality MRI studies. So what type of scanner do you have, for example? An optimal reading of those scans and a training program that is robust for the radiologist interpreting the images. And we know, similar to prostatectomy, who does the surgery, it's the same with interpreting imaging, that experience matters. So the radiology team and the logistics matter. And then the access to high quality MRI targeted biopsies. So also, the urologist who performs the biopsies also needs to be trained, because there could be a false negative if you miss the target that you see on the MRI. And there is this concern about undersampling, that distal apical tumors can be detected and sampled with MRI and fusion biopsy that are otherwise missed. And then the value of transperineal biopsy versus the transrectal ultrasound is still under investigation, and there are large randomized trials underway, although we know that some people have started to use this method already now based on detection rates and reduced risk of infectious complications. And there are ongoing screening trials to further answer the question of the use of MRI together with PSA. So you have ProBase in Germany looking at risk-based screening starting at age 45. You have the ProScreen in Finland comparing risk-adapted screening with 4K score and MRI. You have the Göteborg 2 trial in Sweden comparing PSA versus PSA and MRI and different cutoffs for biopsies, and then using targeted or systematic. You have the Reimagine in the UK, which is a feasibility study of MRI as a screening tool. And then you have the MVP in Canada comparing MRI versus PSA in prostate cancer screening. And there are a couple of other more studies also ongoing around the world. So more evidence to come in the next few years. And finally, another proposal has been this sort of hop, skip, and jump 3-stage approach, where you start with a risk stratification with age, DRE, PSA, risk factors, biopsy, biomarkers before you proceed to biopsy. And then if your risk is sort of intermediate, then you can move on to MRI and then decide to biopsy or not. And if your risk is low, you don't do biopsy. If your risk is high, you biopsy. But again, the sequence and the order of these events is still being explored in studies as of today. And the NCCN guidelines say that biomarkers that improve the specificity of detection are not as yet mandated as first-line screening tests, but they are meant to be used in conjunction with the PSA test. And it's not known how these tests should be applied in combination with MRI. And here's an example of a study where performing targeted biopsies only in men who had an elevated Stockholm 3 test could save biopsies and decrease overdetection and maintain the number of high-grade cancers found. So really combining the Stockholm 3 test and MRI could have favorable features. And here's similarly another study that showed performing the 4K score in conjunction with MRI similarly led to a reduction in unnecessary biopsy. So more studies on this to come, and I think the evidence continues to grow. So to conclude this trilogy, we recap, we have the 5 golden rules: get consent, start conversations about risks and benefit of PSA screening at 45 to 49, risk stratify screening and adapt the rescreening intervals to the man's age, health, and prior PSA. Don't screen men who won't benefit, so limit screening in older men and those over 60 with a PSA less than 1. Don't biopsy without a compelling reason. Repeat the PSA workup for benign disease and consider additional biomarkers and/or MRI. Recommend active surveillance for men with low-risk prostate cancer and refer men who need treatment to high-volume providers or centers. And this way, you can optimize the balance between benefits and harms of screening. Thank you.
Sigrid, thanks for that presentation and all 3 of them. Really is a classic and a must listen to, and we really appreciate all the information you so succinctly shared with us and our audience, and we hope we can have you back again soon. Again, thanks.